When you see a patient with neuromuscular disease coming in with a high heart rate and an oxygen saturation that's not 96 to 100%, to me, that's a huge red flag.
Hi, everyone, and welcome back to Pediatric. I'm Zach Hodges. I'm a pediatric ICU fellow at UT Southwestern in Dallas.
And I'm Alice Shanklin. I'm a critical care fellow in Washington, D.C.
Alice, will you remind our listeners what we do here at the Pediatric?
Absolutely. Pediatric is a collaborative educational podcast. We want to interview pediatric critical care educators around the world for their best teaching points.
And today we're excited to have Dr. Bill Bortcosh back on the show. Our listeners will remember he's an assistant professor of pediatrics in the Pediatric Critical Care Division at the University of Florida. His interests are in neuromuscular ventilation, and we will discuss that much more today.
Yeah, so this is part one. It's a fantastic conversation. Let's get right to the content.
Hi, everyone. Welcome back to Pediatric. I'm Zach Hodges. Alice and I are so excited to have Dr. Bill Bortcosh back with us on the show today to discuss this important topic of neuromuscular ventilation. Bill, will you remind our listeners a little bit about who you are and what you do?
Absolutely. So I am an assistant professor in pediatric critical care at the University of Florida. I'm an attending pediatric critical care physician. I have multiple interests in neuromuscular patients is one of them, and complex care. I study simulation for parents of children with complex medical needs, such as neuromuscular disease. I also have some specialization in burn care and innovation stuff, and I'm more than happy to talk about ventilation of the neuromuscular patient today. When I first came on, we did a lot of change within the institution to help develop some quality improvement projects and some guidelines to help manage these patients because they have some very specific needs that are unique to this population. And so I'm excited to come here and talk about it. And my fellows and my residents know that I will talk about this ad nauseum.
Nice. Well, that sounds like a great program that you've helped build. How do you define neuromuscular disease?
So neuromuscular disease, it's a very broad term because it can fall into many different categories, right? Someone who has a cervical spine injury, you could technically call neuromuscular disease because the connections are broken and they essentially develop weakness at the neuromuscular level. But you can refer to any problem with the brain, the nerves, or the muscle itself that causes muscle weakness. That will encompass diseases such as Duchenne's muscular dystrophy being one of the most common, spinal muscular atrophy being one that's very common, where national newborn screening just got approved because there's essentially, I wouldn't call it a cure, but there's a treatment for it now. Because there's a treatment, generally there's a lot more public interest and a lot more that we need to know as intensivists because these kids are not only living longer, but they're having increased medical needs that we need to manage as critical care doctors.
Yeah, definitely an example of the amazing things that medicine has done. We're so grateful to be able to take care of these patients for longer.
Absolutely.
So what we're going to talk about today seems to be a broad approach to many different types of diseases, but maybe let's zoom in on a case and use that to unpack the rest of our discussion. Okay. So here's our patient. We have a 6-year-old male with known spinal muscular atrophy who presents to the PICU from the emergency department with respiratory distress. On exam, the child is only mildly tachypnic with respiratory rate in the 30s, but you note paradoxical breathing, nasal flaring, and tachycardia to the 170s, which seems to be out of proportion to the tachypnea. He's also desaturated to 81%. So Bill, what's your overall assessment of the situation and what would you like to do next?
So this is really important. Because these patients are weak, they may not show all the classical signs of respiratory failure that you're used to. You may not see that tachypnea to 50, 60, 70 in someone who's acutely about to fail. You may not see that depth of retraction. They don't necessarily have the muscle strength. So there's a few pathophysiologic variables that we have to address, and we have to understand the process and what's going on. So maybe let's just start talking about some of the physiological characteristics and then how we can intervene and address each one. Does that sound like a reasonable start?
Yeah.
For sure.
So the first things first is functional residual capacity. So this is required intensivist knowledge. So how would you guys define functional residual capacity?
That's the volume that remains at the end of a normal breath.
I love it. I love it. Simple. My favorite explanations are the one that you could describe to someone on the street and they know what you're talking about. If you say it in fancy words and you don't even really know what you said, in my mind, you don't understand it. Exactly. You take a breath and then the amount of air left in your lungs at the end of it, that's your FRC. FRC is important though. So it's more than just the amount of air in your lungs and the breath. It's basically the amount of air and the amount of pressure that's sort of keeping everything popped open. So as we all know, our lungs are basically a lot of little balloons, kind of called alveoli, that inflate, deflate, and they help with gas exchange. FRC is really important because it needs to be maintained above something called the closing capacity. Have you guys heard of the term closing capacity before?
Yeah, we talked most about closing capacity in those intubated bronchiolytics that were worried about them dropping their upper lobe.
Yeah, exactly. Closing capacity is a theoretical value. It's something that we all have at all times. We just don't think about it. You can imagine just imaginary trend line, but basically it's a line, an arbitrary value below which you begin to have more atelectasis. That your FRC would fall below that. So we want our FRC to be above closing capacity at all times. And there's several determinants to closing capacity. Probably the most common one is whether you have lung disease or not. So in someone with lung disease, like restrictive lung disease, where the lungs want to collapse, they want to slap shut, their closing capacity is raised. It's closer to FRC, and it's much easier to get atelectasis because any drop in your FRC will kind of precipitate closing of your alveoli because they're no longer inflated open by the air. So it's really important that we keep it above at all times. So it sort of informs the next question as to why is FRC relevant to patients with neuromuscular disease, or why would I be implying that FRC would be lower in these patients? So have you guys care for patients with neuromuscular disease at your institutions?
Yeah, we've got a couple.
Yeah, somewhat. It seems like maybe every other week on service we'll have one come through.
Yeah. If you were to think about FRC, the amount of air that rests in your lungs at the end of a normal breath, what are the main factors that you think would contribute to that?
So this goes back to your chest wall compliance and your lung parenchyma compliance.
Correct, exactly. So this is a curve where in med school, I definitely did not understand it. But basically, the compliance of the chest wall and the compliance of the lung, the average of them equals the compliance of the respiratory system. And that compliance, as you breathe, kind of like goes up and down, and it forms that sort of beak-like pattern that many of us may remember. Basically, because the compliance of the chest wall in patients with neuromuscular disease is higher, which is interesting, that basically means that the chest can sort of like inflect inwards and sort of deform abnormally during a breath, and that can impair the compliance of the total respiratory system overall. And by that, that's one of the main reasons why these guys have poor respiratory system compliance. There was one study where the person was looking at the compliance of a newborn wall. So you may remember that newborn lung compliance or respiratory system compliance, their chest wall is much more compliant than that of an adult. And for that reason, their FRC tends to be lower, which is one of the reasons why neonates have such a high respiratory rate, because they can't take in big tidal volumes, they breathe faster. And so they said that the chest wall is 3 times more compliant in the neonatal lung compared to an adult. But around like 2 years of age, it gets to about normal chest wall compliance. Neuromuscular patients, a lot of them don't develop that, especially with the ones with severe neuromuscular impairment. And their chest wall can remain 3 times as compliant as a normal adult or even worse. And that can cause permanent deficits in their FRC, and it can permanently predispose them to atelectasis. So making sure that we have good mean airway pressure in the lungs to help pop open those alveoli is essential to caring for these patients.
So if I were to understand this correctly, the core concept here is patients with neuromuscular disease have a more compliant chest wall, and therefore their FRC, that lung volume into exhalation, might fall below that theoretical volume of closing capacity, where there's this vicious cycle where they develop atelectasis and then their lung volumes decrease and then they develop more atelectasis and there's that spiral respiratory failure. Is that about right?
Correct. Exactly. And as you're having more trouble taking in a breath, like your tidal volumes get less, your FRC drops. These are all like dynamic variables, but it sort of feeds into itself. So when you see a patient with neuromuscular disease coming in with a high heart rate and an oxygen saturation that's not 96 to 100%, to me, that's a huge red flag. I don't pay as much attention to the depth of retractions or the respiratory rate, which often are slightly worse than normal, but their lungs are healthy. They have healthy lungs, and that's the important thing to understand. They should not live at saturations of 93, 92. Like that is AB normal. Even 95 might raise an eyebrow from me, because this person should be at 100. And 9 times out of 10 in these patients, the primary cause of this, because they are weak, is secretions. But we'll get there too.
Hey, I'm Ciara Minova, a graduate student of Psychology and Neuroscience of Mental Health at King's College London, and I'm so excited to share with you my new podcast, which is called Behind the Stigma. Every other week, I will be mainly talking to the podcast clinical psychologists, clinicians, researchers, educators in the field, you name it, basically people that I find so inspiring and that will help us understand the latest research, concepts, but also complexities and controversies surrounding mental health. These are going to be some great discussions and a peek into the fascinating world of psychology, neuroscience, and psychiatry.
So one thing we mentioned in our case, that there was some evidence of paradoxical breathing. Do you mind unpacking that more for us?
Oh, yeah. It's so, this is so important. We talk about this in med school all the time, but again, it doesn't really make sense. So let's think about it. When you or I breathe, and again, this is maybe not something that a lot of us pay attention to unless you're like nerding out over respiratory physiology. Take a breath in and breathe out. Now, when you're breathing, divide your body into two parts, the chest and the belly. When you breathe in, does the chest and the belly go outward or inward?
Outward.
Outward. And you breathe out. Do they go outward or inward?
They go inward.
So not theoretically, in reality, the chest and the belly should move symmetrically, outward when you breathe in and inward when you breathe out. And that's because you take a breath in, your muscles in your chest contract, they increase the thoracic cavity volume. Your diaphragm goes down and it pushes the belly down. Your belly is just like a bag. Imagine like squishing a bag. It sort of will if you squish the bag from top to bottom, the sides of the bag will go out. And that's the same in your belly. So that's why they should move symmetrically. Now, in someone with weakness of the chest wall or weakness of the abdominal cavity or weakness of the diaphragm, sometimes these muscles don't work good. And when muscles don't work good, they do weird things. So just very simplifying it, because it doesn't matter which muscle is more weak than another. If you see someone take a breath in and their chest wall goes out and their belly goes in, or vice versa, what that implies is that person has weakness in some muscles. In a neuromuscular patient, you can infer that it's probably the intercostals and the diaphragm that are weak. And they basically took a breath in, and because their diaphragm wasn't able to push down as much, their belly kind of got sucked in. That's one example of a muscular sort of weakness that could happen. But when you see that, it basically means that the patient's musculature is not able to breathe efficiently. And that is something to address as well. And there is one way to address that. You can basically force anyone to have normal breathing with the right machinery. Do you guys know what that is?
Yeah, they need some positive pressure.
Positive pressure. It's basically, we like to think that in the ICU we do a lot of fancy things, but really all we do is we give PEEP and we place lines. That's all we do. And we have lots of ways to do that, but that's essentially what we do. So positive pressure is the name of the game here. And so when we say positive pressure, basically what you're doing, if you give positive pressure to someone, you're going to make the chest go outward and you're going to make the belly go down. And why is that? So you give a breath in, goes in the mouth, goes in the lungs. That is literally going to force the chest out and it's going to push the diaphragm down. And when you push the diaphragm down, the belly is going to go out. So there's no inefficient breathing here. There's no wasted calories. There's no waste of energy. Basically, everything moves symmetrically in the way that it should move. And then you are basically facilitating more FRC, more lung inflation, and you're preventing atelectasis, which is going to help these guys a lot.
So to wrap up paradoxical breathing, it's essentially when the chest wall and the abdominal wall move desynchronously during the respiratory cycle. So that being maybe the chest is trying to expand, but the belly similarly sucks in, and it leads to ineffective ventilation. Similar to decreased FRC and concerns for elevated closing capacity, you fix this with positive pressure, with PEEP. Mm-hmm. And that's just another kind of reinforcement of how important it is for positive pressure to support these patients.
Exactly. You see paradoxical breathing, this patient's too weak to breathe and their volumes are inefficient. And so you need to support their tidal volumes and support lung inflation and help them breathe synchronously and re-recruit that FRC. Exactly.
Another pillar kind of from our reading, thinking about the respiratory dysfunction in these patients, is disordered control of breathing. Will you tell us more about that?
So this is actually an interesting one because it's not commonly talked about in the critical care setting. If someone's in that PICU and they stop breathing, it's not, this is going to sound callous of me, it's not a big deal. It's our job. We know that they stop breathing, you go in, you bag them. If you need to, you put in a breathing tube, blah, blah, blah. Though in this population, I would recommend against putting in breathing tubes, but we can talk about that later if it can be helped. So basically, these guys are susceptible to disordered patterns of breathing and disordered breathing with sleep. And that can have long-term implications because like these guys aren't going to be in the PICU forever. They're going to have to go home at some point and live their lives. A lot of people with Duchenne's and Becker's and spinal muscular atrophy, these guys are living well into their 20s. And because these treatments of Spinraza, Zolgensma, and all these other stuff, viral vectors and genetic stuff is coming out, it's really important that we think about sleep-ordered breathing because it's going to affect the overall health. And then the likelihood of sudden death at home is going to prevent that. So this one guy, Abu Suan, I'm butchering that. He did this wonderful paper on disordered breathing. And essentially, he said there's 3 categories. 2 of them are obvious, and one I don't think we would necessarily instinctively think of. So the first obvious one was obstructive sleep apnea. That almost seems like a given. You're weak. You have proximal muscles that are weak in Duchenne's and spinal muscular atrophy, very common. You have muscles in the neck and the chest that are weak. So when you fall asleep, it can go like, it doesn't take a logical leap to think that, okay, this person's muscles in their neck, their bulbar space are going to kind of fall back, their tongue, they may obstruct at night. And so obstructive sleep apnea, as we know, it carries risks of poor development, it carries risks of mood issues, it carries cognitive risks, it also carries an increased risk of sudden death. So it's important to think about how can I stent open the airway, stent open like the bulbar musculature such that I can sort of prevent this. And this is like well known not just by doctors, but also by lay folk as well, that the way to do this is
positive pressure.
Always. PEEP. Yeah, exactly. So CPAP would be appropriate to address that. The second type of disordered breathing is hypoventilation. And we kind of alluded to this. Essentially, if you're not taking in good tidal volumes, we all remember that minute ventilation is equal to tidal volume times respiratory rate. So these guys may not be able to generate a very good respiratory rate, and sometimes they're not able to generate a good tidal volume. So it would make sense that we would want to support both those things. Now, the thing with hypoventilation, so if you found someone who lived in rural Florida, had Duchenne's, just wasn't cared for, and then you brought them in and you did a blood gas, you'll probably see that their gas looks something like 735, CO2 of 60, 70, with an elevated bicarb. And that would imply what sort of acid-base disturbance?
Primary respiratory acidosis, and it's chronic, but partially
chronic.
Compensated.
Yeah, exactly. And so these guys, they just take shallower breaths. But because we know it's tidal volume and respiratory rate, PEEP is not, unfortunately, can't fully address this. PEEP can re-recruit some alveoli, but this enforces the idea that in patients with moderate to severe neuromuscular disease, oftentimes CPAP is not enough. It's important to give them a tidal volume on top of that PEEP. The PEEP will recruit some FRC. It'll help prevent atelectasis, but it won't give you that extra oomph in your tidal volume. It's hard to know for sure, but these guys might be breathing at 5 per kilo, 6 per kilo, and that can go down overnight. If you give them that extra, that little bit of extra 5 centimeters of water pressure, 10 in some folk, but usually you don't need too much, that will bring their tidal volumes up to the 8 to 12 mLs per kilo range, which is where these guys are very happy. They have nice inflated lungs. They don't atelectasize as often at all. And that's kind of where I ventilate all these guys. When I come in and my first year fellows ventilating them at 6 per kilo, this will often spur this unfortunate 1 hour sort of teaching conversation with them. But all of us have this sort of learning where and I did it as a fellow too, where I ventilated them in the 6 to 8 per kilo range, which I was used to ventilating most people. They would have more events of bradycardias and hypoxias either throughout the day or overnight. So keeping that bi-level pressure can prevent this hypoventilation and sort of prevent events throughout the day and overnight, just such that everyone is just happier.
Huh. Can you explain the danger of tidal volume again? I feel like I don't.
Oh yeah, we're so chicken in the 2000s. It's so funny. So if you look back to how people used to ventilate, everyone was at 12 to 15 cc's per kilo, everyone. And and when I was raised as a fellow, it was oh my gosh, you need to ventilate everyone at 4 to 6 per kilo, 8 per kilo if you're feeling spicy,
Oh, yeah.
And it all was generated out of the ARDSNet trials in 97 and stuff, where they found that ventilating these guys at 12 per kilo was killing them. And the comparison group was 6 per kilo. There was nothing in between. And this was ARDS patients with nasty, restrictive, fibrotic lungs that would just rip at, and you touch them, it would just rip, And so kind of like we alluded to before, patients with spinal muscular atrophy, patients with Duchenne's, they don't have lung parenchymal issues. Their lungs are fine, and we don't need to be scared of ventilating them like this. So in my mind, there's this is mildly tangential, but there's 2 populations of patients that I like to ventilate in the 10 to 12 per kilo tidal volume range, and they're for different reasons. One is neuromuscular patients, and that is to maintain that beautiful tidal volume, maintain that FRC, prevent atelectasis, keep them well above closing capacity. And then the other population, assuming that this patient population doesn't have bad lungs, is cardiac patients. And the reason for that is a lot of these guys need positive pressure ventilation to reduce their afterload, and a lot of them are post-op and stuff. But you'll find when you do the math that the primary driver of near airway pressure is more respiratory rate than it is tidal volume and PEEP, which is actually very interesting to me. So if you ventilate them at a high tidal volume and a low respiratory rate, you keep a lower mean airway pressure, and that way you can prevent, positive pressure will reduce preload to the heart. And by maintaining a lower mean airway pressure, you can kind of like maximize your preload while giving them really effective ventilation and also sort of giving them a high FRC and preventing atelectasis. So I've actually moved in the vast majority of my patients who don't have lung parenchymal disease and are intubated to ventilating them at least 8 to 10 per kilo, just because I find that they have fewer desaturation and atelectatic events overnight that way.
Oh, nice.
Yeah. Thanks for those practical tips. Kind of circling back to disordered control of breathing for these patients. You mentioned obstructive sleep apnea, they require PEEP, hypoventilation, and that blunted response to a chronic respiratory acidosis.
Correct.
So far we talked about how these patients with neuromuscular disease, they might have a decreased FRC, they might have paradoxical breathing with chest wall weakness, and now we've unpacked the disordered control of breathing.
I should say there's one more type of disordered control of breathing that I didn't mention. And this is the one that may not be as obvious. And that is that these guys have apneas, pseudocentral apneas. So you're right, hypoventilation was one, obstructive sleep apnea is the other, and pseudocentral apnea. So when I say central versus, it implies versus peripheral apnea. What I mean by that is that it's very hard for even pulmonologists to differentiate between central and peripheral. But basically peripheral apneas are when you have obstruction of the bronchioles, obstruction of something in the lower respiratory tract. So you essentially see like an atelectatic event, and the baby or the patient will hold their breath, they'll desat, and they'll become bradycardic. Whereas a central apnea looks more like you're breathing normally, breath out, and then just no breath and nothing. And that kind of comes to what you just mentioned, which is they have a blunted response to hypercarbia. And so because we know these patients have pseudocentral apneas, especially at nighttime when the brain is just kind of like in sleep mode, literally and metaphorically, this is why it's important not just to have a tidal volume, like a PIP on top of the PEEP, but also a rate. So you can't just put them on BiPAP with a spontaneous rate overnight in the moderate to severe neuromuscular patient. It's important to have a backup respiratory rate in these guys as well. So the point of bringing up disordered breathing in these guys is to emphasize that in many of the neuromuscular patients, CPAP is not quite enough. I prefer BiPAP with a backup rate of at least 5 or 10, just to kind of prevent everything. That will address the obstructive sleep apnea, that will address the hypoventilation, and then that will address the pseudocentral apneas as well.
Nice. And do you mind teasing apart here the difference between central apnea and pseudocentral apnea? In my mind, if you drive someone's CO2 down by hyperventilating them and then they don't breathe, that's central apnea. And then if someone is so weak and then they get weaker overnight and then they appear to be having no respiratory effort for a period of time, is that the pseudocentral apnea?
Oh my gosh, this is like such an academic question. It's like, this is a question for like big nerds,
Round with Okay. Either way, it's happening.
Yeah, no, you're right though. It's important to discuss. So traditionally, central apneas are like thought of like apneas in the line of Ondine's curse. So like you guys have heard the story of Ondine's curse. There was a guy named Ondine. He was like super good looking. He used to look at himself in the water all the time. It pissed off some god. The god came down and saw him. Hey, Ondine, hey, I've noticed that you're really good looking. I'm gonna give you a blessing. I'm gonna make it so that you can look at yourself in the water all the time. And I'm gonna make it so that if you ever sleep, you're gonna stop breathing. So you need to stay awake always. And Ondine never slept again, and he just lived a horrible life. And there's actually like a FOX2B gene or something that is like called Ondine's curse, is a mutation in that. But that's the very like non-PC description of what Ondine's curse is. So that is traditionally what is thought to be a central apnea. It's something wrong with the brain or with your genetics. Make the brain, but because this is pseudocentral, because their brains are good. Technically, they've just been exposed to these hypercarbia over time. They're used to it. And so this is just like the brain's natural adaptation to a situation that is inflicted on them by their neuromuscular stuff. But like, it's so academic. It doesn't even matter in like what you do in your day to day. If you're going to do research on this stuff, or you're going to go sit in conferences, I think you should probably like have sort of some sort of script that you go in with your like coattails and your 3-piece suit and all that stuff, but it just doesn't matter.
Yeah. No, but I was wrong because it's not like indicative of a true lesion. It's just the way that they've been compensating for a while and their body's responding. Gotcha. Thank you. And thank you for listening to this episode of Pete's Grit. Please remember that everything discussed is intended for informational and educational purposes only. It should not be used as a replacement for medical advice. The views expressed during this episode by hosts and our guests are also their own and do not reflect the official positions of their institutions. If you have any comments, suggestions, or feedback, you can email us at pedscritpodcast@gmail.com. You can also check out pedscrit.com for detailed show notes and visit @CritPeds on Twitter and @PedsCrit on Instagram for real-time show updates. Thank you again for listening.